All right. All right, we're going to go ahead and get started. Thank you all for being here. I just wanted to first give a warm welcome to Grand Rounds for the new academic year. We're going to start off the year by going over what I hope is a really timely topic. And I'm very pleased that Dr. Wells, Dr. Kominski, and Dr. Rice are here to walk us through this and to give us some more information. So without any further delay, I will hand it over to them. Thanks.
Great. Thanks for being here, and I really want to thank Tom and Jerry for joining us. It's really been fun preparing, sharing our perspectives, our differences, and we'll lay that out, and it's a very timely topic. So I think many of you know me. We're all going to introduce ourselves. We decided just to show the partnership. And so I'm Ken Wells. I'm a psychiatrist. I have an appointment here and direct the Semel Institute Center for Health Services and Society. I also have an appointment at the RAND Corporation and at the VA and the School of Public Health. So, Jerry.
Yes. I'm going to speak here, apparently, because I don't have a lavalier. Hi, I'm Gerald Kominski. I'm a professor in the Fielding School of Public Health, Department of Health Policy and Management, and also have a joint appointment in the Luskin School of Public Affairs in the Department of Public Policy. I am currently a senior fellow at the UCLA Center for Health Policy Research. I was the director of that center until just this time last year.
And Tom.
My name is Tom Rice. I'm pretty much the same introduction as Jerry. I'm a health economist. I'm in the Department of Health Policy and Management in the Fielding School of Public Health, and I have a joint appointment in the Department of Public Policy and the Luskin School for Public Affairs.
Great. And for those of you who maybe are not as involved in School of Public Health issues and so on, these are really top policy analysts in the country and internationally. So it's really great, and they both have a lot of expertise in Medicare, Medicaid, and the kinds of things we'll be talking about today. All right, so we're going to tag team on the slides and then join in a discussion. We're going to try to manage our time so there's plenty of time to talk with you, answer your questions. And if we go through something that actually needs some attention at the moment, because just like we're talking Greek or something, you know, kind of raise your hand or say stop, and then we'll have some discussion in real time. And then first, we have no conflicts of interest related to this subject to declare. And then you're next.
Yeah. So we are going to be tag teaming, as Dr. Wells said. So I'm going to start by giving you just a brief background of the Medicare program, because we're talking about Medicare for All. And I was considered during the 1930s as the Social Security Act was being signed into law. Ultimately, Franklin Roosevelt decided not to pursue national health insurance in 1935. So it wasn't until 30 years later that the law was passed. I also want to call to your attention, there are people in the room who lived through this moment. I'm one of them, although I was a kid when this event took place. But the person sitting to President Johnson's left is President Harry Truman. And the reason that Harry is sitting in that seat of honor, and this signing took place in Harry's hometown, Independence, Missouri, is because of his support for national health insurance during his presidency. Those were unsuccessful attempts, but Harry was a vigorous advocate for national health insurance during his term as presidency. So Medicare was enacted over 50 years ago, 54 years ago. We're going to be celebrating the 54th anniversary. And it was the culmination of 8 years of legislative experiences. There's a good book on this, The Politics of Medicare. It's a fascinating history, but the point that I want to emphasize today is that although I'm not a historian per se, the Medicare program itself allows for the opportunity to speculate whether this law would be enacted today. And it certainly was not easy in the 1960s to pass this law. And I could argue in a format where we had more time that without a confluence of unusual historical events in 1963, 64, and 65, this law might not have been passed. But when Medicare was enacted, it was basically two programs. It was Medicare Part A and Part B, both of which can continue today. Medicare Part A is true social insurance. You don't choose to participate in Medicare Part A. When you get paid, you have a deduction on your payroll. 1.45% of your taxable salary goes into the Medicare Part A program, and your employer contributes 1.45%. And Medicare Part A is primarily facility-based, hospitals, skilled nursing facilities, rehab hospitals. It's facility-based care. Medicare Part B is voluntary insurance, primarily covers physician services and ambulatory services. It's financed through a combination of monthly premiums that beneficiaries pay, as well as general tax revenues, as opposed to a dedicated tax like Medicare Part A. Since 1965, there have been several major expansions of health insurance in the United States. The Social Security Amendments of 1972 expanded Medicare to include disabled individuals and ESRD patients, people with renal failure. In 1997, we had the Children's Health Insurance Program, which in some sense was a consolation for not having national health insurance passed under the Clinton administration. So later in the Clinton administration, there was an attempt to do something about uninsured children, and there was bipartisan support, and that led to Children's Health Insurance Program, known as SCHIP. Medicare Part C, which is basically Medicare managed care, today it's known as Medicare Advantage, was originally passed in '97, and then this dramatically reduced the percentage of uninsured Americans. You can see when the law was passed in 2010, 18.2% of the non-elderly population in the United States was uninsured. That's down to 10.7% today. The other graph that I want to show you before I hand the next part over to Dr. Wells is the percentage of uninsured in the U.S. population by year of age. And I really like this slide. If a picture's worth 1,000 words, this slide summarizes everything that's right and everything that's wrong with the current system of U.S. healthcare financing. If you look above age 65, virtually everybody's covered. There are some seniors who are not eligible for Medicare, and as a result, there is a small percentage of residual population that's uninsured. With children, partly because of Medicaid and because of the SCHIP program, we're doing a pretty good job of covering children. In the state of California, the uninsurance rate for kids is around 1%. It's lower than the national average, so we're doing a really good job in California. It's the working age population. But what you can see in this slide is that the ACA has dramatically, across the entire age distribution, reduced the percentage of uninsured, particularly for younger adults. And I have that red arrow there to indicate age 26. That's the cutoff for young adults to stay on their parents' policies. So the age category, or the age group that has the highest rate of uninsurance in the United States, 26-year-olds. The cutoff is 25. So with that as background, we'll transition to the next part.
Thanks, Jerry. So we're going to now, it's in a sense, backpedal a bit and talk about the history of what's happened in behavioral health financing. And I'm just going to spend 2 minutes to tell a little bit of a personal story, which is when I decided to go into psychiatry, it really was because of my sense that there was something that really needed fixing in the mental health, behavioral health systems that we had in this country, whether it was in particular hospitals and stigma and the marginalization of psychiatric care in discussions administratively, or the lack of parity in healthcare. And I had no idea how I was going to address that. And after I did the clinical scholars program here and got exposed to a much broader way of thinking and got my master's in public health, I was fortunate in being invited to lead the mental health analysis of the health insurance experiment, which is the largest social experiment in the history of science. And I'll talk a bit about that. But the personal aspect of that is this was really transformative because I worked with leading economists, not these two, though we talked about it, but people like these two, and learned to think about issues that I had no background in from a systems perspective. And for 20 years of my career, that was the focus of my career, was how do you bridge understanding how insurance management of services affects quality and outcomes of care, which led me to another gap, which is how do you really get in reality better services in the community and addressing disparities. And that Jeannie Miranda, who's here, and I really focused on for the next 20 years. So I just wanted to share that, especially for the young people here, that I think it's very important to identify and track your passions and figure out who you can get, like really good colleagues, to help you think in the way you need to think to address them and go forward, and to keep working on that problem even later in your career. Anyway, that's my little personal message. All right, so behavioral health policy. So the first big point is coverage has expanded and contracted over the last 50 years or so. And 20 years before the ACA, that period of time, the coverage of mental health addiction services in insurance was typically less generous than medical. And also under management, there typically has been stronger management, more careful oversight, more denial of claims, and so forth, than for medical services in the private sector. Now, why did this occur? Some of it was based on, it says principles, bias, market, and some data. So, for example, some of it was stigma. Some of it was the market. People were not demanding as much because they're nervous about getting services. So that affects the demand, and then insurers feel, well, I don't have to. And then also there was some data, especially from non-experimental studies, that that cost of mental health care was more price responsive. What that means is if you have more generous coverage, it goes up more than services use and cost than use of medical services. So the way you handle that is you do less generous coverage to get a similar response to price changes, both for medical and mental health. And the health insurance experiment was done to figure out that issue. Is it real, or is it what's called a selection bias, which means that sicker people go to more generous plans, so of course they're using services more. That's a selection bias. Or is it a real price difference response? And that was of interest to inform national health insurance, both on the general medical side and on the mental health, behavioral health side. So the non-experimental studies were suggesting that it was very much more price responsive, but was that due to selection bias? Opinions were very strong, findings were mixed, and there often is like a 10-year, 15-year lag between the data becoming and what the market is doing. So now you figure that out, but now the market's on to managed care, and it's a different question, right? That's what often happens in policy work. And then another issue is these complex changes, like even the history of Medicare or what the terms are for coverage are often not very transparent to communities or even providers. So we're delivering services and suddenly someone says, actually, you can't be reimbursed for that. Kind of, huh? What's happened? And so how do we get transparency? And then I just want to note that in addition to coverage issues, there are other system issues in mental health. Access, some of that is the stigma that we talked about. Quality, some of that is not uniform standards around training and evidence-based practice. Outcome disparities, where under-resourced communities, communities of color, LGBTQ, and so forth, may not have as good an outcome because they are not accessing the evidence-based strategies as much. Rural areas access. Inpatient psychiatric beds. We know that there's a greater shortage today than 10 years ago. And then provider training and evidence-based practices. So those are all issues that you might say, even if we fix the insurance problem, we still have to fix other aspects of systems, trainings, to get a better mental health system. And then just a couple of quick points. One is mental health doesn't sit alone. We know there's a lot of comorbidity with medical conditions and dual diagnosis with substance abuse, and all of that affects not only what we need to do clinically, which are all, those of you who are residents, so forth, being trained on, but what we need to think about, the system connections, the silos that we have. How do we get around them? What is insurance doing to address them? And also the social determinants of health, and so forth. I forgot this was animated. Okay. And then the little touch of sentimental history, the health insurance experiment, which I mentioned. And if anyone still reads hard copy, I brought a copy of the book about the summary of the findings called Free for All, ? And the RAND reports, and there are a zillion articles. These are the RAND reports on mental health that that I was involved in that we're going to briefly summarize. So this is a randomized trial of variation in family insurance conducted from 76 to 81. And my faculty appointment began in 1980, so you see how lucky I was to get assigned to that study 1 year before the data collection ended. And there was an individual deductible plan, a free care plan, and then various co-insurance plans, which were different co-insurance rates up to a cap, after which care was free. And then in one site, these were also compared to an HMO that was in Seattle. So what we found is that mental health care costs were actually quite modest, even under free care. That's because the demand was much lower than the need. So it's kind of like, well, what's the big deal here? If it's going to be even under free care, the costs are not that high. Why are we over-managing insurance? Also, the mental health services costs were less in less generous plans. So yes, reducing insurance did reduce costs. And mental health costs were more price responsive when it was free from selection effect, because these were randomized plans, but much less than you would expect from the observational studies that showed 3 to 5 times as price responsive, and it was maybe 50% more price responsive than use of medical services and costs. And then while there was no significant effect on mental health outcomes of insurance variation, there was a significant three-way interaction such that the poor with poor mental health, basically the Medicaid population, had their best well-being outcomes under free care than any cost-sharing plan. Whereas those with either lower income or higher income and good mental health tended to do better with a little bit of cost-sharing, to avoid overuse of unnecessary services. So anyway, that's the health insurance experiment. And then quickly, the next big opportunity to look at these kind of questions were the Parity Act, which came before the ACA. So that was 2 years before. And then the Affordable Care Act built on the parity legislation. So currently, the federal law we're under is both parity and ACA, which in combination have sort of special effects for mental health. So not to go so much into the details, but the Mental Health Parity Act was mental health only, not addiction. ACA added on addiction. So it became behavioral health parity under the ACA. Group plans were the subject of the Parity Act, the Affordable Care Act, added on Medicaid, and then added the insurance exchanges and so forth. The financial coverage, which was the same under both, was around annual and lifetime limits, deductibles, copays, across mental health, surgical, and medical coverage. And then treatment, it applied to visits, coverage, other limits on scope and duration of treatment, and then, as I mentioned, the ACA added addiction. Okay, so what do we know from various studies? Obviously, this is not a randomized trial. These are now observational. And after the full implementation of parity, one concern was, would plans drop behavioral health care or mental health care because it was not required to have it. It's just if you had it, it had to be with parity. But there was no evidence that there was dropping. But some plans that were supposed to do parity still offered benefits without parity. So it's not like there was a police service saying, are you doing what you should be, now we penalize you. And so there was, most states still allowed utilization control on substance use services, which was not under the Parity Act. There were few effects on use of behavioral health services in studies, except one child study, and there was actually evidence for increased SUD out-of-network use and little data on quality of care. Then along came the ACA, and there was, as Jerry pointed out, a decline in uninsurance in those with mental health disorders, a decrease in perceived unmet need for mental health care due to cost in studies that included those measures. There was an initial increase in mental health services under the ACA, but only for 1 year. And after that, it went back to what it was before, and little effect in the first 2 years for substance use services, except in young adults where there was an increase in mental health and a decrease in substance use. So again, that gets back to my point about other systems issues that need to be addressed, not just coverage. We can get coverage much better, but then we still have these other problems, the silos, the evidence-based practices, the stigma to address from a public health perspective. And then this is a slide from Jeannie's new chapter, which we'll refer to at the end, of the impact on disparities. You can see that in addition to improvements overall, there were some substantial improvements in disparities for Asian Americans, Latinos, to some extent African Americans, but African Americans are also overrepresented in states that did not expand Medicaid under the ACA. So now we go on to Medicare for All and today's questions.
So let's transition I'm going to set the stage by talking for a few minutes about why Medicare for All is on the agenda. And I'm glad that Dr. Wells included the previous slide about the impact on disparities. We're currently working on a report that'll be published in another month or so on the impact of the ACA and the health insurance market in California. And it's a much better picture in California in terms of reductions in disparities. Because we've got a state that's embraced, not only expanded Medicaid, but also embraced the ACA. So in that case, in states that are making it work, it's working to reduce disparities considerably. So why is Medicare for All on the agenda now? Why now? Why is this an issue? Obviously, we have an upcoming presidential campaign, but there are a couple reasons I want to talk about. One is the ACA is working, as I've tried to convince you earlier. But if you recall the graph that I showed you a few minutes ago, 10.7% of the non-senior population in the United States remains uninsured. So the best projections when the ACA was first enacted was that we'd get to 9% uninsured rate among seniors. So in a sense, the ACA's done about as well as anybody expected, but it's left lots of people behind. The ACA is still vulnerable to both congressional and judicial repeal. And by the way, as we speak, the 5th District Court in New Orleans is considering the latest constitutional challenge to the ACA. A Texas judge found that the ACA is unconstitutional last year, and this case is now working its way through the appeals process, and arguments are being heard today about whether or not this will be the 3rd constitutional challenge of the ACA since it was enacted. You've got approximately 19 million people today who have insurance who did not prior to the major provisions of the law going into effect in 2014. They stand to lose their health insurance completely. I spoke to a reporter the other day. She said, "What's at stake?" I said, roughly 20 million Americans stand to lose their health insurance overnight if this law is upheld in the appeal process. But in addition, there are an estimated almost 130 million Americans who may be insured now, but who have pre-existing conditions. And, you know, we all have pre-existing conditions for the most part. We're vulnerable because if we change jobs, or if we decide, for example, to leave a large employer and become self-employed, or work for a small startup firm, we could be denied health insurance coverage once again because of a pre-existing condition. Those protections are essential to the ACA, and they go away if this court case is upheld by the appeals court. There's also an increasing sense of financial vulnerability among people with employer-based coverage. Remember, the majority of Americans get their health insurance coverage through their place of employment. And to a large extent, people are satisfied with their employment-based insurance. But there's this increasing sense of vulnerability because in the last 20 years, we've seen this rapid growth of high-deductible health plans offered by employers that put individuals at greater financial risk. Oh, and finally, Senator Bernie Sanders in 2016 openly embraced a Medicare for all single-payer system. And I think much to the surprise of a lot of us in the field who study this, there was much broader based support for a Medicare for all plan than I think almost anybody predicted. And so as a result, you're seeing this now being openly embraced by a number of the leading candidates in the 2020 Democratic primaries, upcoming primaries. What are the options that are currently being considered by Congress? Well, there's the single-payer plan. We're going to talk about that, and Dr. Rice is going to go into this in detail, that Senator Sanders has introduced. This is the Medicare for All proposal. But I just wanted to call to your attention that there are other options that are, in a sense, less comprehensive, but nevertheless would increase insurance coverage in the United States. There are several bills that would create a public option, which was originally intended to be part of the ACA but never made it to the final version of the bill for a variety of reasons that we can discuss in Q&A. There are both Medicare and Medicaid buy-in options that are being proposed that would allow people to buy into a public program if there's not affordable insurance available in the marketplace or through your employer. So there are a variety of options from extremely comprehensive to let's try to improve the marketplace and fill in the places where people continue to fall through the cracks. Now, before I turn it over to Dr. Rice to talk about the details of Medicare for All, I just want to define a few terms. First of all, single payer, which is the Medicare for All proposal, is not, let me repeat, is not socialized medicine, okay? It's a form of national health insurance. There are three general categories or types of national health insurance that we see around the world, and particularly in high-income nations. There are single-payer programs, which is what Medicare for All would be. That's public financing with a private delivery system. Hospitals, doctors, et cetera, are private providers of health care. This is what Canada does. This is what Sweden does. There is socialized medicine. Socialized medicine is generally public financing and public ownership of the delivery system. The best example is the UK. Although even in the UK, the delivery system is, doctors are private providers of care, but hospitals are largely public. There are some private hospitals in the UK, but the vast majority of patients are seen in public hospitals. Then there was what's known as all-payer systems. This is public financing with multiple insurers and public regulation of the payments to private providers. And this is actually the most common form of national health insurance that we observe around, again, particularly in high-income nations. Germany, France, Switzerland, Netherlands, Israel. These are all nations that have a all-payer or multiple-payer system, but highly regulated. National health insurance does not necessarily mean that there's no private insurance or co-payments. Private insurance is available in a lot of these countries to cover benefits that are either not covered in the national health benefit package or to cover co-payments. Final point that I want to emphasize before I turn it over is that Medicare for All that Bernie Sanders is proposing is not the current Medicare program open to the rest of us, okay? It's not that. And Dr. Rice will go into the detail. So with that transition, I'll let him tell you what it is.
So you probably heard the most about Senator Sanders' proposal. He's had a couple bills. The most recent one was introduced just a couple months ago in April, and it, as you can see here, has received the co-sponsorship by several of the prominent Democratic presidential candidates. What he is proposing is a truly fundamental reform of the U.S. healthcare system, something of the likes we've never seen, and you could argue goes beyond what other countries are doing as well. A few characteristics. First of all, it does provide universal coverage. Secondly, it does it by essentially shedding our employer-based health insurance system, which 180 million Americans have. And that's where a lot of the debate is going to be as we go forward, because as Jerry mentioned, people in polls say that they're happy with their private health insurance through their employer. The proposal is extremely comprehensive. It includes benefits that aren't included anywhere domestically or really almost anywhere in the world. For example, home and community-based as well as institutional long-term care, covers dental care, vision, hearing aids, even reimbursement for some transportation costs for lower-income people. As you'll see in the next slide, things are free. So what about mental health care? Well, the bill doesn't talk about mental health care very much, but I don't think it has to. To quote it, it says that it covers mental health and substance abuse treatment services, including inpatient care. There's really not much more to say. It's covered, it's free. So imagine a world in which all mental health care is free, and that's what's being proposed here. Now, which providers would be eligible to provide that is something that would have to be determined by the government later on. But it would be a very different world for mental health care. A little bit more detail. I mentioned long-term care. Long-term care is a tremendous burden in the United States for seniors. Medicaid is now covering 50%. Medicaid, as I understand the bill, would pretty much cover everything. Right now, people pay about 40% of long-term care expenses, and so this would be a tremendous relief for them. The remarkable thing about this is everything is free with one caveat. There are no deductibles. As mentioned, average deductibles are pretty high now, I think over $1,500 a person in employer-sponsored coverage. There'd be no co-insurance. There'd be no co-pays. You know about co-pays for prescription drugs. There wouldn't be any. There'd be no premiums. Premiums are tremendously expensive. They would not exist. There would be no balance billing. That means that once the government determines what the fee is going to be for a service, a provider cannot charge the patient more. The fee that they get from the government would be payment in full. The patient would have no liabilities. The only cost sharing I could find in the bill is you could pay up to $200 a year for prescription drugs on copays, but that's it. So how do you control costs? Well, one thing that it does, and other countries have done as well, is there's a global budget, an annual global budget, which presumably Congress would set, and we would try to adhere to. But you can't just set a global budget. You also have to have other things in place that are going to allow you to meet the global budget. And one thing they're going to do is negotiate prescription drug prices with manufacturers, something that isn't allowed right now. But there are other ways in which a so-called single payer system can control costs, and I'll mention those on the next slide. So I want to talk, first of all, about some advantages of Medicare for All, and then some concerns. On the advantage side, first of all, it provides universal coverage. We saw that 11% of non-seniors are uninsured right now. This also appears to be rising. We don't know for sure, but if you look at one source of information that's very current, the Gallup, the polls conducted by Gallup, they're showing a marked increase in the number of uninsured. It has not been confirmed by the, I don't want to call them more reliable data sources, the standard data sources we usually use in calculating the number of uninsured. But there's a concern that it's rising. This makes sense because the Trump administration has made a point of making it more difficult for people to enroll in the healthcare marketplaces and exchanges. Also, we're seeing a little bit of a whittling away in some states of Medicaid eligibility, but particularly through work requirements, although that hasn't had a big effect nationally yet in the numbers, although it could. Another advantage, it eliminates most financial barriers. How could it not? Everything is free. The Commonwealth Fund estimates that if you just ignore the 11% of uninsured non-seniors and you take the insured non-seniors, 28% are underinsured. And this is mainly because we have insurance companies, you wouldn't have insurance companies providing the services covered, and almost all services are covered. Insurance companies have a lot of administrative costs, higher administrative costs than the government. A lot of those savings would vanish. Some would not vanish. You still have to process claims, but some would vanish. For example, marketing, risk rating, things like that. Not just the insurers. You wouldn't need nearly as many staff in hospitals or doctor's office to deal with insurance because it would be so simple. I've been reading a book about the French healthcare system, and French doctors can't imagine having anyone in their office that would deal with billing because it's so straightforward. So a lot of the administrative costs are on the provider side. You also wouldn't need reimbursement specialists trying to maximize revenues the way we have now in hospitals. So there would be lower administrative costs. It could also reduce some provider payments. I'll talk about this more in a slide or two from now. But the single-payer systems take advantage of something economists call monopsonistic power. This is a monopoly, but on the buyer side rather than on the seller side. So basically, there's only one buyer services. In this case, it's the government. If there's only one buyer services, as we found from the Canada's experiences with their provinces, they can cut pretty good deals. And the idea is that provider fees would be lower because the government would have more bargaining power than it does have now. And just to show you some of the fees, looks like those are pretty visible. This compares 7 countries' fees for different services. I'll just look at a couple of them. Let's take one drug, Celebrex, US $225. Pretty much twice as much as the other countries that had data, 4 times as much as Canada. Look at one diagnostic. We'll look at MRI. The US, the highest by, well, New Zealand was pretty high too. US is more than twice as high as the other countries. It was 9 times higher than Switzerland. Switzerland, many people view as having maybe the finest healthcare system in the world. We're paying 9 times as much for MRIs. Hospitals cost per day, more than double New Zealand, triple Australia. And then possible that single payer will exact some of its savings. I'll just end with 2 slides about concerns. With regard to costs, the Urban Institute, which is an independent research organization, estimates that federal spending would go up by $33 trillion over a 10-year period. Now, this doesn't mean that healthcare costs would go up by that. That which can be balanced by people paying less money, other savings in the system. But this is $33 trillion that has to be raised by taxes. And you can think about that in the current tax environment. I'll return to that as well. Administrative spending, in my mind, definitely would be lower. But I don't know if provider fees would be so much lower. You have to understand the political system we have here, the role of interest groups, are interest groups going to let fees get as low as they are in other countries? Even under single payer, I'm very doubtful that that would be the case. With regard to efficiency, I'm going to just put up the first two. In some ways, it's argued that single payer would be a step backwards. The US is the most innovative country in the world with regard to managed care. And what is the incentive for managed care if you get everything for free? Why would you want to be in a limited network when you can be in a network without limits and you'll get it for free? So there's a concern that this could, unless they do something, bring us back to a pure fee-for-service world, which generally is recognized as very wasteful and certainly not cost-containing. Also, remember, fees are going to be lower. You can't get extra from patients, and this is sort of an age-old problem in international health policy. How do you encourage quality if quality is not rewarded through the reimbursement system? It's a I don't, if you ask in Q&A, I don't have a simple answer for this. This is a question that, our field has been grappling with. And my last slide, more concerns are political. And it's all about the transition. So remember, single payer may not cost more. It may actually cost less. But taxes are going to have to go up dramatically. So where is this money going to be coming from? Well, it's going to have to be coming from people paying less. How do I say this right? We're paying a lot of money right now. If that has to be replaced by giving us higher incomes. So employers are no longer going to contribute. Employees are no longer going to contribute. If employers don't contribute, the idea is they're going to raise your wages because wages are in a competitive market. So that's where the money's coming from. You're going to be paid more, and you're going to pay less in premiums. The question is, are you going to be able to convince the public that's going to occur? That these $32 trillion in higher taxes are going to be made up by the fact you're going to be making more money and you're going to have more disposable income because you're not paying your part of premiums. That is going to be a really tough public sell, I think. There have been 2 ballot initiatives on single payers I'm aware of, California ages ago and Colorado 2 or 3 years ago. Both received only about a quarter of support. What happens when these bills are put before the public is there's tremendous interest group, opposition by interest groups, and they're able to convince the public it's not a very good idea. Vermont did enact single payer. It never got implemented when it became clear what the tax increases were going to be to Vermonters. So anyway, there are really big political issues here, but a lot of people think that we've got to do something big right now because our system is rather dysfunctional. And the last point is something that I just want to mimic what Jerry said, is that some people think that it would be better to put our political energies into shoring up aspects of the ACA, something more incremental than doing something as dramatic. So I think I turn it over to Ken for maybe the last slide.
Yes. Sorry to be putting so much information out, but hopefully it's it's a good time to have this information. So I thought we would end with just reflecting for a moment, and then we'll go into discussion to give you plenty of time to ask questions of what are the roles of mental health professionals in realizing expanded coverage goals, whether it's coverage goals, Medicare for all, something else, revision to the ACA itself. One is embracing more of a public health perspective, thinking more about prevention, stigma, and including in that public health perspective, the public policy and awareness of the economic consequences of what we're doing and attention to disparities. Implement a range of evidence-based practices more rigorously as a nation. I mean, UCLA, I think, residencies and psychology programs and so forth require a fair amount of that, but later on in practice, what happens to the decay, right? And then expanding prevention and early intervention programs because they're maybe underutilized in the mental health area, but that could be some way of getting at some of the cost concerns, is doing more upfront. Monitoring quality and outcomes and improving our data systems. We need those skills. We need it to be done. Working with stakeholders towards implementation. It's not just us coming up with ideas. How do we really engage in order to have successful implementation and outcomes, whether it's an evidence-based practice or Medicare for all or whatever? Develop new models of delivery in partnership to increase equity as well as reach and quality. I think we've attended to this less in mental health because we're more on the defensive, battling back to get equal coverage. Some of that's been achieved. Where do we go now? Evaluate the cost effectiveness and comparative effectiveness from a societal perspective of these different models. We need to know how to do that. And if we as clinicians are not involved with our economist colleagues and so forth in doing that, it's not going to have the clinical meaning. It needs both. And then, advocate for inclusion of consumers and community members with behavioral health conditions so that actually consumers understand these issues. If we think we're struggling with it, our consumers need to know that, and then training the next generation. So those are some of the things I think just kind of our charge collectively. And then I just wanted to call out this new American Mental Health Policy book. You can get it, the PDF, through the UCLA library here. Jeannie has a chapter. It's a really nice overview of what's happening in American mental health policy, where we headed, and then the Kaiser Family Foundation report on Medicare for All and other public plan proposals that has been alluded to. Those are nice resources, and then discussion. So, Jeannie, all right.
Great, thank you so much. This was amazing.
Where's our... Sorry. Oh, there you've got it. Yeah, no, he's right there.
Thank you. This is great. I have a question. One thing that wasn't mentioned is that bankruptcies almost became half under ACA, because most bankruptcies, so many are actually related to medical problems. So that's where there would be a cost savings. And you mentioned there were concerns about quality, but we pay more and have worse quality and outcomes than most systems that do have one payer. So I really think there are ways. For example, there would be much more incentive for preventive care where there isn't now, because people change insurance companies so frequently. So I think the data would suggest quality could go up. It's certainly, we pay more and have worse quality than most countries, so who have different forms of care. So I just wanted to bring those two issues up.
Do you want to start or me?
No.
Okay. Oh, I've got that. I agree that if we have better coverage for preventive sort of services, that should improve population health. I read the quality literature somewhat different than that. If you look at life expectancy, look at infant mortality, the U.S. is by far the worst, and there are other measures like that too. But I think most of the evidence I've seen is it indicates that it's more of a problem with regard to socioeconomic status. There's some data that indicate that cancer care in the United States is the best in the world. If you look at the Commonwealth Fund's mirror reports, we do horribly with regard to access and the cost. We're actually kind of middle of the road with regard to quality. The key, I think, is to try to find measures that you think are going to be influenced most by the medical care system. And there's one measure, though, that's called mortality amenable to health care. Things you shouldn't have died of, that the healthcare system did well. The U.S. does terribly in that, but my reading of that measure is there's an awful lot of SES caught up in it. So I think that we're still, the jury's out about how poorly you do. I will agree that we are hardly the best internationally among wealthy countries.
Jerry, you want to add anything?
No.
Okay.
I had a question.
There was someone in the back first. Is someone in the back? Raise yeah, right there, raised your hand. I'm sorry. Sorry, Tom. We'll come back to you. I'm just trying to be fair, equitable.
Sorry, Dr. Strauss. Thank you. That was extremely helpful. I'm wondering what Medicare or how Medicare for All would deal with health care for undocumented immigrants.
So
We're wondering too.
I think we're wondering, but I think that the candidates, when asked this question, said that it would cover all residents.
Right. That's what Kamala said anyway, I think. Yeah.
The Democratic candidates. Democratic
Yeah.
candidates. Oh, yes, let me be clear, the Democratic candidates.
Yeah, let me just add something there, that the only country in the world that actually has the same coverage for the undocumented and documented people is Thailand. There are some countries in Europe that are pretty generous about it, but there's no country that does what all 10 of the hands said that they would do. And you have to ask, even if single payer passed, whether politically it would be possible to do that, because there has not been a lot of popular support to extending the same health benefits to the undocumented. So it really ends up being a political question. I don't know if the word undocumented shows up in the Medicare for All proposal.
No,
so I think that they're trying to avoid that issue right now.
So we're fortunate to work in a health system at a university that continues to express a commitment to operating a freestanding psychiatric hospital in an era when the psych hospital is an endangered species and when we lose money doing it every year. My question is, do you have a projection as to what, under single payer or Medicare for All, whatever we would call it, will there be incentives for hospitals and health systems to build or maintain inpatient psych beds? I realize in a perfect world where there's prevention, maybe we would need fewer, but I'm confident that however many the minimal number is, we don't have that many in this state, right, probably in this country. And more broadly, what will incentivize the creation of outpatient services to address these access concerns?
So I think Tom correctly identified that part of the incentive, the financial incentive, comes from the fact that everything's covered and everything is free because it's tax financed. In other words, there's no out-of-pocket liability, no cost barriers, and so economically, this creates an incentive for providers to expand their services to take advantage of the fact that those services are now going to be fully covered. Of course, the question is what happens in 30 or 40 or 50 years when the building starts to wear down and you need to replace. I think our experience with the Medicare payment systems, and Medicare's been paying hospitals fixed payment amounts since 1984. And the hospital industry has contracted, but I don't think most analysts think that it's simply because of the fixed payments. There are, Medicare has an allowance for capital improvements and for capital investments, and I think this can be resolved in the political system. It's done that way in other countries through global.
I'm going to add something general about single payer, but then Ken can address the specifics about psychiatric hospitals. One of the concerns that some people have about single payer is that because it's a government program based on taxes, it has to compete against every other financial priority that a government has. And we see, particularly in the countries that have this, England, Sweden, Canada, these are the countries that have the longest waiting list among the wealthy countries. And my assessment of this is because the government has to be worrying not just about healthcare, but education and defense and transportation and housing and everything else. Systems that rely more on payroll taxes seem to have money that's more earmarked to healthcare. Those tend not to be the single payer systems, although in our preparation, Jerry pointed out to me that the Sanders proposal said it doesn't have to be income taxes, it could be payroll taxes. But one worries about protected money in healthcare versus other priorities that, sort of bears on your question.
Yeah, I was just going to add, to make it even a somewhat more complicated situation, as you know, one of the things that happens with psychiatric inpatient beds are the very long stay because of the community problem of not having enough either residential facilities or homelessness and so on. So it's also the fit of psychiatric inpatient bed and costs with a broader societal problem. So in a sense, we need not just Medicare for all, but Medicare and social society for all, or whatever it would be, social security for all or something, I don't know. Because how would, so that's part of the issue, right, is the very long stay patients. So I think some kind of projection of what reimbursement would need to be and what the broader system would need to be to have more stable growth and stable number of psychiatric beds. So maybe that's a commentary to work on afterwards.
So we're at the end of the hour, but I just wanted to thank you all three for presenting to us.